Thank you, Dr. Bankasa. Thank you for the kind introduction. And with the permission of the chairpersons, I would like to share my screen. Yeah. So the case. So it's a young chap, 34-year-old with the cardiogenic shock. He's in Killip Class 4, already on inotropes with increased lactates. We have well-documented evidence of systemic hypoperfusion. His lungs are all congested. He's already intubated, had a primary VT, DC verted, with severe elbow dysfunction and moderate MR, and yes, he's been attempted for the primary PCI. So again, this is a very classical and unfortunately a rather common scenario that we face, and it is important that we realize what can we do about this. So Sky has recently come up with this, has recently modified, actually this was an expert consensus, this has been modified, and the pyramid identifies and classifies shock. Stage A is a patient which is otherwise hemodynamically stable but has a risk for cardiogenic shock, like patients with an acute MI or decompensated heart failure. Patients who have hemodynamic, stage B is hemodynamic instability without evidence of hypoperfusion. Stage C is systemic hypoperfusion. Stage D is patients of stage C which deteriorate despite doing some intervention or escalation of therapy, and state E is extremist shock. So unless a patient comes with out of cardiac arrest and with an anoxic brain injury, wherein the patient will be directly classified as stage E. Otherwise, by default, patients with systemic hypoperfusion end up being classified as initially as stage C, and then they are either they deteriorate to stage D or improve to stage B. So Sky has again in that expert consensus set a 3-axial model of prognostication and evaluation of cardiogenic shock. We need to identify the phenotypes and etiology, whether it's an acute and chronic etiology, clinical etiology of the cardiogenic shock, right ventricular type, LV type, or biventricular failure, cardiac versus cardiac pulmonary failure, congestion profiles, and biochemical phenotypes. The severity of shock, the staging of shock can help you identify this, and the various risk modifiers like age, comorbidities, cardiac arrest, presence of other organ failures, and infections. So this entire staging is a continuum. The patient can either improve or deteriorate in either ways. So there are deterioration paths and there are recovery pathways. So when a patient with cardiogenic shock comes, so coming slightly back to our case, acute myocardial infarction with cardiogenic shock, our aim is to provide circulatory support, increase the mean arterial pressures. We do this by inotropes. Our patient is already on inotrope. We can add an IBP or ECMO or impeller. Yeah. Hello. I think we can, because of the congestion, we can unload an LV. Am I audible?
Yeah, Rupesh, go ahead. Prashant, you can mute.
Yeah. So we can, put in diuretics, inotropes, IBP, and impeller to unload our LV. And we can obviously, the most important, improve coronary perfusion. This is again done by PCI or including CABG. So again, from this consensus, they have presented this algorithm in which patients with acute myocardial infarction, whether undergoing a high-risk PCI or having a clinical evidence of shock, they have put forward an algorithm to follow. It is said that using MCS prior to PCI or in patients with cardiogenic shock helps, and that is what has been said in this algorithm. So what are the MCS devices which are available to us? IVP has a modest increment of only 0.5 in the cardiac output and power. Impeller CP, tandem heart, and ECMO with increasing LV assist that they can provide. So what are the various mechanisms? We all have undergone this. This is a slide which has been presented again and again over various meetings, and we are very familiar with this. Let's stick to our question and let's look at IVP and impeller. More or less very similar. Impeller no doubt has a better power or better efficiency, I wouldn't say efficiency is that, but it is more potent in its way to increase the arterial pressures or improve the cardiac output. So, but is IBP bad? No. So, what is the basic physiological? The augmentation has been around for good old. The concept of augmentation was started in early 1960s. So, I guess it predates me and my colleague. So, an IBP has been around for a good 50 years. And the logic of using IBP has been very clear. So, IBP will improve the coronary perfusion and decrease the left ventricular afterload, and a combination would allow a better coronary perfusion and decrease the myocardial work. So over a period of time, we have seen in various studies and practically also that IBP has been used for cardiogenic shock in patients with acute MI, in post-infarction cardiogenic shock, for LV unloading, refractory ventricular arrhythmias, perioperative care during cardiac surgery, and even for non-ischemic cardiogenic shock or non-ischemic heart failures, and also as in support for high-risk PCI. So what do the guidelines say about IBP? It is interesting to know. I was just going through the historical data, and it was said before the days of reperfusion or PCI, IBP was actually shown to improve mortality. But as we had more potent ways of revascularization, the benefit then started getting clouded, probably because reperfusion had a stronger, effect. So before 2004, IBP use was a class 1 in recommendation in cardiogenic shock. However, in an update of that same 2004 guideline, it was slightly downgraded and to a class 2A. Similarly, this was the US guidelines. In the European guidelines, till 2008, IBP was a class 1. In 2010 onwards, it was downgraded. A majority of this discussion about IBP started after the IBP Shock 2 trial, in which, after which the use of IBP was downgraded to class 3. And in both the 2014 and 18 guidelines for myocardial revascularization. And however, they have said that it is still considered or a class 2 indication in patients with an acute myocardial infarction with mechanical complication. This is the ACC guideline on myocardial revascularization. That is the last available version. It says on IBP, in selected high-risk patients, if elective insertion of appropriate hemodynamic support as an adjunct to PCI may be reasonable. So it's a class 2B indication. I would also point out or bring to your attention the paragraph or the text that follows this, and it has said that Impella, though provided better hemodynamic support, but unfortunately was not able to translate into a better mortality. A lot of data with IBP and a lot of data with Impella as well now. Unfortunately, cardiogenic shock is a milieu which is very hard to study in randomized controlled trials. So a lot of these studies have been retrospective in nature, a lot of meta-analysis, and a very variable kind of result. So, but there are enough studies now which showed that IBP had mortality reduction in patients with failed PCI or in high-risk patients undergoing PCIs for acute myocardial infarction. Similarly with Impella, again, the data is slightly dicey. It's more of the use that has been coming up because of various factors, because of the kind of support and the pathophysiology that Impella offers. Let's compare the two. So this is a whole timeline of the studies that have compared the various mechanically circulatory support options in acute myocardial infarction and cardiogenic shock. And so let's look at some of these trials. In the Aisha shock trial, a small study with randomized patients to IBP or Impella 2.5, effectively no survival benefit. Though it was documented Impella had a better hemodynamic support. The IBP Shock 2 trial, again, though this does not compare, this was the study which drive IBP out of fashion, and they had around 600 patients and they classified it to IBP versus no IBP. But though a lot of talk is based around IBP shock 2 trial, the study had its limitations. Firstly, only 70% of the enrolled patients presented with STEMI, and among these, more than half had a non-interval myocardial infarction. The timing of cardiogenic shock development has not been clearly documented in this study. IBP was implanted after the PCI in almost 90% cases, which is not what is recommended. We all now recognize that IBP insertion prior to the PCI may help, or for that matter, even impella insertion prior to the PCI helps more. Fourth, almost 50% of the patients enrolled a resuscitated cardiac arrest, and which is a very bad MOLE on stage E extremist shock. Again, the median duration of counter IBP use was 3 days, and most of the deaths that occurred after this period. Also, there was a lot of crossover from IBP to non-IBP to IBP group, and so apart from this, statistically speaking, the mortality rate in the control group was only 41.3%, which was less than the assumed mortality rate of 56%. So this brought down the power of study from 0.8 to 0.6, and that is why, like, though we can, it's an important study, we pay due respect and regard to it, but
time is someplace. Yeah.
So again, IMPRESS, IBP was impella, no mortality benefit. So somebody compared like impella support in IBP shock to matched patients, and they found that again, no mortality benefit, higher vascular and bleeding complications. So this is a meta-analysis for IBP use, IBP versus non-IBP, and IBP versus other LVADs, predominantly impella. And the forest plot shows effectively there is no statistical difference. A lot of other studies comparing IBP versus impella, mostly retrospective in nature, as I said, because of the milieu of the disease, and unfortunately, none of them very definitive. So some trials addressing this, let's see what light they shed. Practically, I guess it is the timing of insertion is very important. In early pre-shock state, IBP insertion might help. Again, I would like to point out this statement: IBP insertion should be considered in acute MI complicated by cardiogenic check when other mechanical circulatory devices are not available, which is the case in here, which is likely the case with my patient as well. So two position papers, one is from EAC. Again, I would like to point out IBP should be considered if other devices are not available. This is from AHA. They also say IBP or impella in their cardiogenic shock algorithm. So IBP is not out of the picture. Impella has a better hemodynamic support, but I don't know if that translates into mortality benefit. So this is probably Dr. Bharadwaj will speak on this. This is impella has been, so this started with Detroit. I mean, as a Detroit cardiogenic shock initiative, they put forward the concept of shock teams and the shock algorithms, and they did show some benefit, like compared to their institutional history. This was later translated into the National Cardiogenic Shock Initiative, in which I find my colleague as one of the authors. And so they have said that there is some mortality reduction and better results. Unfortunately, this is a single-arm, non-randomized study. And of the almost 280 patients, if I'm not wrong, only 171 were randomized. So a lot of gray area here. And really, let's reread the question. What is the preferred device? Preferred device should be available, should be accessible to the patient, should be actually feasible. In our case, IBP is good enough. That's the only one which is available. And I don't think so impella would do any other magic that IB cannot do.
So first of all, thank you, Dr. Kamal Sharma and all the organizers. I think this is a fantastic meeting, and I tuned in a few minutes earlier, and I heard the previous session as well. So this is very educational. So and thank you for the opportunity to be here. It's indeed a pleasure to be here, and a great presentation on IABP, Dr. Rupesh Singhal. I hope you guys can see my screen. So I'm going to be talking about Impella and, arguing that Impella is the best strategy in this patient. So like it was mentioned initially at the beginning of the talk, I practice here at Loma Linda, California, and we are in the southern part of California, and we are a pretty big cardiac program. We do about 100 Impellas a year, which includes both high-risk PCI and cardiogenic shock. We also do LVADs and heart transplants. So a pretty busy program. So I'm not going to go over the details of the case, which was already discussed, but just to sort of highlight some of the key takeaways and summarize what this case is talking about. So this is a case of acute MI with cardiogenic shock, which is very important. Sometimes we tend to put all cardiogenic shocks in the same bucket, but it's important to distinguish the etiology of cardiogenic shock. Acute MI is very different from acute decompensated heart failure or myocarditis type of cardiogenic shock. So this is AMI cardiogenic shock, number one. Number two, it is SCAI stage D, C to D. I would argue that this is D. I mean, initially he has been tried on vasopressors, like Dr. Sharma mentioned, low dose noradrenaline. A lot of times we get transfers from other hospitals saying that, the patient is on low dose noradrenaline, and you get the patient and they are on 25 mics per minute. So I think this is SCAI stage D. The patient also has moderate MR. And more importantly, the patient has a lactate of 8, which is a very important thing to recognize, that this patient is pretty far down in the spiral, the death spiral of cardiogenic shock, as it is called. There's a lot of data to show that lactate is an important predictor of mortality in these patients with cardiogenic shock. And anytime the lactate is more than 4, that actually means that the survival is under 50%. So a lactate of 8, I would say this patient's mortality is very high unless you pull out all the big guns and treat him very aggressively. So I am going to be talking about Impella, which is the best strategy, but this is sort of going to be what the agenda for my talk is going to look like. So first we'll look at the comparison of MCS devices, which was already touched upon previously. We'll focus on the Impella family of catheters. We'll talk about the hemodynamic benefits of Impella, which is, I think, very important. We'll talk about the best practices for use of Impella in cardiogenic shock. And finally, I think, we're talking about balloon pump and Impella in this case. Some people might argue that this is a case where we would go straight with an ECMO because the patient has hypoxic respiratory failure, has advanced cardiogenic shock. So would ECMO be an ideal choice as the initial MCS in this patient? And I think that is reasonable. But even if you do that, there is a role for Impella for LV unloading, even in the presence of ECMO. So I want to touch upon that as well. So I'm not going to, belabor the contents of this slide because I think everybody is quite familiar with this. But just to sort of drive home some key points, I think what we do need to realize, just a comparison between balloon pump and Impella. So balloon pump only modestly increases the cardiac output, at best maybe about half a liter per minute, as compared to Impella, where, depending on what type of Impella catheter you use, most commonly we use Impella CP, which is the one that is implanted in the Cath lab for cardiogenic shock, and that improves the cardiac output by about 3.5 to 4 liters per minute. There are also the surgically implanted Impella devices such as 5.0 and 5.5, which I'll touch upon in a little bit, which provide a greater cardiac output of up to 6 liters per minute. But I'm going to talk about the hemodynamic benefits of Impella, but before we do that, let's quickly look at the devices in the Impella family other than CP and 2.5. So like, 2.5 was the initial Impella that came out, provided cardiac output of about 2.5 liters per minute. Pretty much, I think most centers across the world have stopped using 2.5 at this point. Definitely not indicated for cardiogenic shock where you need higher degree of cardiac output support. So for cardiogenic shock, our go-to catheter is Impella CP, which, like I said, provides about 4 liters of additional cardiac output. And in addition to these, there is the Impella RP, which is the right-sided support device, which basically is indicated in patients who have acute RV failure leading to right-sided shock. and it was traditionally implanted through the groin. Now there is the Impella RP Flex, which is being implanted through the IJ. It is still being studied in a few select centers, and will hopefully be available in the market sometime soon. Then there are the surgically implanted devices, Impella 5.0, LD, and 5.5 with Smart Assist. So this is just a comparison of the devices. Like I said, RP is a right-sided device, 22 French, and insertion method, like I said, percutaneously via femoral vein. Impella 5.0, LD, and 5.5 are all left-sided devices, provide left-sided support, provide a forward cardiac output of about 5 to 6 liters per minute. And these are surgically implanted. So either you need an arterial cut down, most commonly implanted through an axillary cut down. And the advantage of these devices is that they provide greater degree of cardiac output and they allow for patient ambulation. So a lot of patients who are waiting for a heart transplant, waiting for recovery, get an Impella 5.0 or 5.5, which can be left in the patient for several weeks, hoping that their LV recovers. So like I said, it's most commonly implanted through axillary cut down in the OR. So let's quickly take a few minutes to review the hemodynamic benefits of Impella, which I think are quite unique compared to the other mechanical circulatory support devices that we have available. So first and foremost, it increases the forward flow and the mean arterial pressure, like we've talked about, as a result of which it increases the cardiac power output and increases end organ perfusion. But more importantly, something that is quite unique to Impella, which no other device does, is it draws blood from the left ventricle and expels it into the aorta. So by that action, it decreases the left ventricular end diastolic pressure and end diastolic volume, which has a lot of beneficial effects. So decrease in LVEDP and LVEDV result in decreased wall tension, which causes decreased microvascular resistance, which in turn increases myocardial perfusion and decreases pulmonary congestion, both of which increase the oxygen supply to the myocardium. Additionally, Impella also decreases the mechanical work of the heart, as a result of which the myocardial oxygen demand is further reduced. And I am going to explain this in a little bit. We'll come back to this in a second, but there's an important term that needs to be understood, and that is called cardiac power output. Cardiac power output is basically mean arterial pressure into cardiac output divided by 451. And Impella increases the cardiac power output. So just remember this formula, because it's a very important formula, which is part of the NCSI algorithm, which I'll talk about in a little bit. So the ISAR shock trial was talked about. So this was a trial looking at Impella 2.5. Remember, not the CP. It was the 2.5 versus balloon pump. It was a small trial which was definitely underpowered to detect any clinical outcomes. But we do have some other data from this trial which showed that in the Impella 2.5 arm, when patients were supported with Impella, the Impella actually augmented the cardiac output by about 2.2 liters per minute. And like you can see here, when somebody is put on Impella, what happens is that the patient's native cardiac output or the native cardiac index goes down. So in other words, the patient's native heart is resting and is able to recover when they're having an acute MI, whereas Impella takes over the function of the heart, as opposed to balloon pump, which augments the native cardiac output by a little bit, but it's certainly not taking away and is not reducing the work of the heart. So this is a pretty nice illustration of how Impella improves end organ perfusion. And this is what is called a side stream dark field imaging. And this actually looks at the sublingual circulation. So this is the sublingual circulation in a patient with the Impella device turned off. And after 48 hours of support, you see how Impella has improved the end organ perfusion, recruited all these capillaries, and there's nice robust flow in all the different branches. So This is an important illustration because, again, it helps us put things in perspective as to what exactly the Impella device does. So there are two things that we need to recognize when we're treating patients with cardiogenic shock. One is hemodynamic support, which is important. You want to sustain life. And number two, there's something called myocardial protection. So with ECMO or with balloon pump, like I said, what it does is it's not really letting the heart rest or recover, as a result of which, you're really not protecting the myocardium. So Impella is the only category of MCS devices that protects the myocardium. And what I mean by that, let's go back to the pressure volume loop. Not to go into great detail with this, but I think it's important to touch upon this. So I think we're all quite familiar with the PV loop, where you have left ventricular volume on the x-axis and left ventricular pressure on the y-axis. And so this is the diastolic filling.
We are short of time. If you can just
sure, I'll quickly go through these. So the pressure volume area is basically a sum of these two pressures here. So it's the stroke work and the potential energy. Stroke work is a measure of the mechanical energy, and potential energy, like we know, is the stored energy. So what pressure volume area is, it's a sum of these two. And in the interest of time, I'm going to quickly go through these. What Impella does is it basically modifies the pressure volume loop to look like this. So it's narrow and it's taller, as a result of which it's reducing the pressure volume area, reduces the mechanical and potential energy, and reduces the myocardial oxygen demand. Now, in addition to that, as a result of active unloading, the wall tension is decreased. And when you reduce the wall tension, there's reduced microvascular resistance and increased myocardial oxygen supply. Not to go into the details of this, but basically this is just, again, another illustration on a perfusion scan with Impella turned on, where you have nice recruitment of capillary flow, and the perfusion defect actually goes away. So far I've just been talking mostly about all the physiology. So let's quickly review some data before we wrap up. So the National Cardiogenic Shock Initiative, I think, was mentioned previously. We were part of this at Loma Linda. So it's a prospective, non-randomized, single-arm, multi-center study. We enrolled about 406 patients. 697 patients were excluded, mostly because of standard inclusion-exclusion criteria. I'm not going to go into the details of this, but I think this is sort of the meat of the matter, if you will. So this is the NCSI algorithm, which stresses on rapid identification of cardiogenic shock, Cath lab activation, femoral access. You confirm the diagnosis of AMI cardiogenic shock, and you insert the mechanical circulatory support. So like we have door to balloon time of less than 90 minutes in STEMI patients, in shock patients, our aim should be to provide a door to support of less than 90 minutes. So like it was previously mentioned, very important to initiate the mechanical circulatory support before you do PCI. Now, one of the really groundbreaking things about NCSI is that it put a lot of emphasis on right heart cath, which is very important. How else will you make decisions on escalation or de-escalation of MCS in patients with cardiogenic shock? So there are two important metrics to remember. There's the cardiac power output, and there's pulmonary artery pulsatility index. So cardiac power output tells us how the overall heart is doing, and pulmonary artery pulsatility index, or PAPI, tells us how the right ventricle is doing. So the algorithm is here. If you have any questions, you can reach out to me even later on. But basically, if the CPO is less than 0.6, that means that you either need to consider RV support if the PAPI is low, or if the PAPI is okay, you need to consider increasing the LV support. So what we really want to achieve is a CPO of greater than 0.6 and a PAPI of greater than 0.9. So why is NCSI so important? So this is a comparison of the survival in all the previous shock trials. So the shock trial, the culprit shock trial, IABP shock trials, historically the survival of patients in cardiogenic shock at 30 days has been in the 40 to 50 range. But if you actually look at these curves, the curves on top are the NCSI survival curves. All the way at the top is Sky Stage C and D, which had survival of 77%. And if if you look at all comers, which also included Sky Stage E, the survival was 68%. So clearly a signal towards increased survival as compared to all the prior shock trials. This is how these patients were enrolled. We were, like I said, one of the enrollers, and this is the publication. Our final publication is in consideration right now at JACC Interventions, and hopefully should be out soon. But in the interest of time, I have a few more slides before we wrap up. And this is an important point to make, because even if you go with an ECMO, like I said, ECMO increases afterload, and it actually is detrimental to the pathophysiology of the heart in patients with cardiogenic shock. So Impella should be considered for unloading even in the presence of ECMO, the so-called ECMELA or ECPELA, and there is actually data to suggest this as well. This obviously is not a randomized control trial, but this is a large registry of patients showing that an ECPELA strategy or an ECMELA strategy is associated with better survival as compared to just VA ECMO alone, despite an increased risk of vascular and other complications. There was improvement in survival. So in conclusion, Impella actively unloads the left ventricle, increases cardiac output, improves end organ perfusion. Most importantly, it helps with native heart recovery by decreasing myocardial oxygen demand and improving supply. If you are using Impella, it's very important to follow best practices in cardiogenic shock: early identification, Impella pre-PCI, use of right heart cath. I think without a Swan-Ganz catheter, you cannot make any decisions. And finally, Impella is recommended for LV unloading even in the presence of VA ECMO for all the reasons that I just mentioned. Thank you.
Thank you.